appears to be that same phenomenon of, if we can just slow down our rate of growth, we can still live. And when we grow up these organisms on the agar plate, we can biochemically identify them as Staph aureus, but they look significantly smaller. What we're going to discuss now is a persisters subpopulation. And this speaks to antibiotic resistance, not necessarily due to biofilm formation. And then we can also have environmentally induced antibiotic resistance. But let's go ahead now and focus on these persisters. I've given you a copy of this article. It was free on PubMed, so we're not breaching any copyright restrictions. But these two authors have done a fantastic job at looking underneath and beyond biofilms about what actually causes persistent bacterial infections. And this appears to be multimodal in its approach. So as clinicians, I think we need to be exploring beyond the biofilm and looking, are there any other factors happening? And oxidative stress, this link up here, what they found fits in beautifully with how our immune system is looking to defend when we get a pathogen in the body, which we're going to bring together over the next few slides. Adaptive plasticity was a term that was first coined in 1958 by Walsh McDermott. And he was observing way back then, almost 70 years ago, that bacteria have a way of playing dead or transforming themselves by adaptive plasticity. Goes back to slowing down their metabolic growth rate so that they can survive even if the environment is not conducive to giving them all the foods and nutrients they would otherwise prefer. And this hide and sleep hypothesis that I mentioned, it does underlie all of the models proposed for chronic disease. And it speaks to, if we look, bacteria moving into either a slowly replicating phase or a non-replicating phase of growth. Now, historically we have, and we still do, call this the stationary phase of growth. And just to recap you on that, bacteria have 5 or 4 distinct phases of growth. They have a logarithmic phase. Now this is when they are entering the host, and they need to then obviously gain entry, but then start to be looking at an environment where they can start to multiply. Now this logarithmic phase is what we would call often the prodromal phase. If we are sick, coming down with a cold or flu, etc., in that case it might be a virus, but we're not feeling so good. But this is the window when we can normally do quite a lot from a natural perspective in terms of bringing in high dose antioxidants and antimicrobials, antiviral substances as well. Then the bacteria move into the second phase where they have a process here of exponential growth. This is our logarithmic phase. Now at this time they are busy enjoying the nutrients from the host. It's normally not a symbiotic relationship by any means. It's a parasitic one where they're taking from the host to gain their own population growth and numbers. And then they move to the stationary phase. Now the stationary phase we can see quite evidently in vitro setting in an agar plate, whereby we culture the organism up after one day. It might be in a non-selective enrichment agar such as blood agar. The first day the colonies are lush, they're great, and they are receiving those nutrients, blood, amino acids, etc. from the agar plate. We put them back in the incubator for another day. They're still looking pretty good, and then for about day 3 we start to see changes in the agar plate, and we start to see the actual agar itself shrinking or necrosing away from the outer periphery of the petri dish. And this is the classic point at where the bugs and the nutrients have reached a plateau where there is not enough nutrients to go around. In that phase, the organisms again, most likely as a self-protective mechanism, go into this slowly replicating phase, or stationary phase. And then once the nutrients, be they in the petri dish or be they in the host, diminish, that bacteria